It's a pleasure to introduce Dr. Erin DuPree. She did her undergraduate at UC Berkeley. She received her medical degree at Columbia, and she did her Obstetrics and Gynecology residency here at Mount Sinai. She is a practicing obstetrician gynecologist, and she's also the Deputy Chief Medical Officer, Vice President of Patient Safety in the Office of Excellence in Patient Care. Her expertise is in providing the clinical departments with leadership around methods to improve patient safety. In addition, she has worked with malpractice carriers to create risk management councils, and she's currently working with the Joint Commission Center for Transforming Healthcare to improve safeguards to prevent patients from wrong site surgery. She's going to talk today about patient safety at the Mount Sinai Medical Center.
Hi, everyone. Thank you for having me here today. Thank you, Erica, for opening this topic. And it seems like a cozy group. That's why I'm sitting right now. It seems awkward almost to stand in front of this as a small group, and I hope to I didn't set it up as much of a discussion. It's in a lecture format, but please feel free to make it, more casual. And if you have a question as I'm going along, please bring it up. I'm happy to talk or expand in certain area, any area that's of interest to you. And so let me just walk through. As hopefully all of you in the audience are aware, but might not be, so I wanted to phrase the talk certainly with where we stand with healthcare errors and adverse events in healthcare today. 3 to 38% of hospitalized patients have iatrogenic injury or illness. There are at least 2 million nosocomial infections per year, and on average, at least 7% of patients suffer some kind of adverse drug reaction. And those are just a few of the alarming statistics that are present today. We know that in terms of American deaths, if you look at the number of car accidents, the number of women that die from breast cancer or AIDS, that actually medical errors ranks right up there. And this is from the Institute of Medicine study that came out in very late 1999 that showed that 98,000 people approximately die from medical errors each year. And hopefully that's the background that you're all familiar with. And if you look at just how hazardous is healthcare, it's interesting to sort of look at it with the perspective of other hazardous, so to speak, industries. And many of us think of healthcare as a place where we heal people and do no harm, yet it's actually become a hazardous industry on par with nuclear power, bungee jumping, and other, say, dangerous things. And if you, I don't have a pointer, I don't think, if you look right up there, healthcare is dangerous and nuclear power is considered very safe, along with the European railroads and scheduled airlines. So we all feel pretty safe these days getting on a commercial airline, but if we get admitted to the hospital, should we feel like we're really being taken care of? So where do we go? I mean, why do these things really happen? We know that modern care is complicated, that modern therapeutics can be dangerous. If you look at just the number of drugs out there today compared to what we had 20, 30 years ago, it's astronomical. It's just orders of magnitude different. The tools that we have in our hands these days. And we know that people make mistakes, that human nature is not going to change. Even though you're training the best and the brightest today, they are human, they're not robots. And we want that human element still in medicine, and we're not going to erase errors or prevent all errors. And I think that's sometimes a misconception that you hear sometimes in the safety literature is about actually stopping errors. Really, you're putting in defenses that will stop the error chain. But humans will continue to forget things or make mistakes. And the idea is really to have these systems in place, and it's when certain systems, defenses, and I'll talk more about this later, when those things fail, that's when our patients suffer. And so what are some of the barriers to really getting us there? One is that we know the real catastrophic events in healthcare are pretty rare. Right, the wrong site surgeries, those types of things are rare, and even more so, especially in the state of New York, they're not talked about. Nobody really knows about them. It's not very transparent. You take a state like Rhode Island, it's on the front page of the newspaper every day, where there's a wrong site surgery or a retained foreign body. Here, where the legal climate is very different in the state, it is different. people don't know about things. The public is not as aware of things going wrong. And the idea that practitioners have is that it won't happen to me because it is so rare. They don't see it happen very much in their over a career. They think that errors are associated with poor performance, and the focus is really just on individuals and not on the systems. And this goes along with our whole way of thinking and the whole way we were all brought up in medical culture, which is we're trained to be perfect, and that our knowledge, our competence, all that studying goes along with never making a mistake, which is really false thinking. And mistakes are really seen as a personal failure. And the idea that goes along with this error model is just fix the individual. Get rid of them and it'll be fine. It'll be a better system then, right? Well, hopefully we'll share a little bit different. So I wanted to show a real example. This is an old example. Some of you, like Dr. Office, is aware of this or has seen it before. It is from Mount Sinai from a while back. It was an elderly patient that was evaluated in the emergency department for transient hypotension and was admitted for possible sepsis and a heel ulcer. And there was a bloody stool that was in the emergency department noted by one of the people on the care team, but was really not reported or understood by the rest of the team. The physician and nurse didn't really recognize the severity of the situation for many hours that passed. There was a miscommunication about a blood transfusion, and there was actually a failure then to obtain an ICU bed. The patient goes to endoscopy and dies there. So here we have a preventable death here at Mount Sinai. Those were another case, an OB case. A 28-year-old, gravid 3, para 2, at term, presents to the labor floor with fever and diarrhea. She's not in labor, but she's given some intravenous fluids, and the fetal heart tones initially showed a rate of 150s to 160s, and the patient was out of bed, frequently going to the bathroom, sick with diarrhea. There were decelerations, and the fetal heart rate had showed a tachycardia, but it wasn't really recognized, and it wasn't really monitored very well over the next hour and a half. And around 3, there were some decelerations as low as 90 beats per minute, thought to be variable decelerations. The nurse started some oxygen, called the residents, and the residents checked the cervix. Patient still wasn't in labor. For the next hour, the fetal heart tracing was not obtained. Around 4:30, the fetal heart baseline was in the 170s with decels and gradual return. The residents were called. The fellow was paged. They felt that the distress was reversible. Let's give some more fluids. It's really all just due to fever and dehydration. And then there were more decelerations, a bradycardia, slow return. The PGY3 paged the in-house attending, who was down the hallway in the call room, who arrived and called for an immediate, took one look at the tracing and called for an immediate cesarean, ominous tracing. And they brought the patient to the OR where the fetal heart continued to drop, and there was no beat-to-beat variability, which is a sign of health for the baby. They made first incision, got the baby out right away, and there were very low APGARs of 1 and 4, and extremely abnormal acidotic baby with a pH of 6.77, and baby has minimal brain function. Another sentinel event here at this organization many years ago. Do we still have these events? Do they still happen here? Yeah. How far have we gotten since these cases happened 7 years ago, 8 years ago? Do we still have them? What have we fixed? I'm going to talk a little bit about some of the interventions and the approach that we are taking in the institution and ways to combat cases like this, and hopefully over time having less severe cases and creating more defenses. This is how bad things happen in hospitals, and I painted the superficial story, but underlying all of these were many reasons, not just one error. It wasn't one individual. In the first case, when you list out the errors, a minimum of 30 errors in that case. Each member of the care team contributed to the poor outcome, and some of the systems or lack of systems also did. And that's what you can see when you really break down these cases. is that there are many places in that error chain that defenses could have been put in place, and if only one defense had been a little bit stronger, we would have avoided those adverse outcomes. So how do we get from Swiss cheese to Havarti? That's where we're headed. I always say it's Havarti, okay? So what are our goals? In Mount Sinai, the goals are excellence in patient safety, clinical outcomes, the patient's and family's experience, and the working environment for the caregivers, which is key to leading to excellent outcomes. If you look at safety, and this is safety in a broad sense, in other industries you'll see that there is what's called a pyramid, and you can see the references from 1941. For those of you in the back, it's a very old reference from somebody that looked at accident prevention in other industries, and it's been found to hold true in other industries that for every major injury, sentinel event, like I just described, those preventable deaths, those permanent injury type of cases, that there are 29 cases where there was minor injury due to errors, and yet there are 300 no injury accidents, or what many of us would call near misses, right, or close calls, and those are the free lessons that you're familiar with. And I know you've probably all heard of a safety culture. Oh my gosh, is she going to talk about that again? What is a safety culture? Why am I talking about it? What does it mean? What is a safety culture? I have it up here, right? It's a culture that acknowledges that errors will occur, that values the near misses, that looks for what the issues are that led to the near misses, that learns from the errors, that respects the expertise of everybody on the team, that everybody brings something to the table, not just the most senior person or most experienced, that actually everybody has a different perspective that's important, and that it's a culture of improvement. What the Agency for Healthcare Research and Quality puts forward is this formal definition, which you'll see in many books, is that it's the product of individual and group values, attitudes, perceptions, competencies, patterns of behavior that determine the commitment to the style and proficiency of an organization's health and safety management. Well, that is a mouthful. Are you going to remember that when somebody says, what is a safety culture? I don't. That's why I put it on the slide. What I like to remember, and I think what really encompasses it, is really the way we do things around here. Right? That's the safety culture. So how do we break that down? How do we improve that? That's what high reliability organizations have. That's what the airlines have. That's what nuclear power plants have, is a safety culture. That's what's been found to get them to a better place. How do we in healthcare get to that better place? Well, James Reason talked about something else. And to frame it before I break it down and how Mount Sinai can get to a safer culture, that if you're convinced that your organization has a good safety culture, you're almost certainly mistaken. Okay? Like a state of grace, a safety culture is something that you strive for, but it's rarely attained. As in religion, the process is more important than the product. So it's really the process of continuing to look at your organization, to be open to learning from it and the errors that are present. And the virtue and the reward lies in the struggle then, rather than the outcome. But I would say that our reward is our healthier patients with better outcomes. And that's a reward for our patients and for us, obviously. So what are the imperatives? How do we get to a safer culture? It can be engineered. It can be set up. I know, you look at me like, what? How? Well, so what can we do? It focuses on these three aspects, and James Reason writes about this in most of his books. He writes about organizational accidents, and most of his work has focused more on healthcare over the last 10 or 15 years. And at the heart of that, many people will talk about a just or a fair culture, and I tend to refer to it as a trust or trusting culture, and it's one where people at the bedside, nurses, physicians, house staff, trust that the leadership, their chairs, their residency directors, their managers, the executives will treat them fairly. That those people that don't follow the rules, that willfully intend to do things badly, will be punished for that. But those that abide by the systems and work with them will do well, and they trust that the leadership will make things happen. And when there's a trust that there's fairness and accountability for workers' actions, they feel more safe reporting their errors to the leadership. And that reporting is at the heart also of a safety culture, the ability to report errors, report those near misses, report the adverse events, and that leads to targeted improvements. Right? If you don't get reports from frontline workers, then the improvements that management and the executives dream up are going to have no relation to what's going on at the bedside. So it's very key to get that information from the people that are working on the units at night, on the weekends, and tell what's really going on so that better improvement strategies can be put in place. And then when the physicians and nurses see that capital and resources have been allocated to key safety issues, they're going to trust that leadership knows what they're doing, and it becomes a positive feedback loop, right? So each portion is important, and they all need to be improved on a continuous parallel basis. And that's what I said here. It all revolves around a high degree of trust. That you need the team to trust each other and to point out the errors in each other's performance and feel comfortable doing that. And it actually requires a high degree of respect to do that. So how do we focus on trust here at Mount Sinai? What can we do? What have we done? What are the rules? That's where it starts. Does everybody know what they are? Your policies and procedures are at the heart of a safe culture. Having clarity about what's right, what's wrong. And there are certainly many areas of healthcare that are in the gray, but are there certain guidelines for certain things that we need to abide to? Yeah. Are they clear to everyone? Sometimes. Sometimes it's just a piece of paper and a binder that nobody's looked at in 10 years. Is that really in practice? Is there clarity around our procedures, our processes here? One of the other key things is to be able to differentiate between an individual with a real problem from a good person that's in a system set up to fail. So how do we do that here at Mount Sinai? Does anybody have any idea? How do we do that? When there's one of those horrific events, it's very easy to point fingers and say, well, that was the doctor that was on. Oh, I know he's not the strongest. Yeah. It's very easy to do that, to just point to the individual and not look at the underlying systems. It's much harder, more difficult for leadership to fix the systems. But how, when looking at a case, do you differentiate those kinds of things? Something that's been used, and this is a complicated diagram. I'm going to walk you through the important aspects of it, so don't try to sort out all the 10 font there. The United Kingdom uses in the National Health Service, and that we have adapted for use here at Mount Sinai. And this is actually the physician form, and there's also one that has been developed for nursing and for 1199 union staff. And they're all actually similar in the way they are, but because we are licensed by different professional bodies at the state level, some of the end places are termed slightly different. But the same process, there's parity across the disciplines. So just to walk you through the important parts, that we start here. So when there's an adverse event, like, for instance, one of the ones I described, the first test is the deliberate harm test. Did that practitioner come to work and were the actions intended? Did they intend to harm that patient that day? Was there willful recklessness, right? The next test is the incapacity test. Does there appear to be evidence of ill health or substance abuse? So if no, then you would go on to the foresight test. Did the individual depart from agreed upon safe procedures and protocols? If not, then it becomes a substitution test. If you took somebody of equal experience, qualifications, would they have behaved a similar way in a similar circumstance? If yes, then what you really have are system failures, right? And you go through the yes and no's that can take you to different places, and it can really help leadership understand what happened in an event and to create some fairness in terms of accountability and culpability. And so this is a tool that is used here in certain cases and situations to help understand and ensure that there's fairness in the approach.
Is this
Yeah.
available printed somewhere?
It can be. It's used as a tool by quality in certain cases.
Well,
If other people would like it, it certainly could. Yeah. It's been around for a couple of years, yeah. What? It's never been distributed. It has, and I'm not saying it can't be. It just hasn't been. I think it's been used as a tool, mostly by internally looking at serious adverse events, inequality, and risk. When there are situations that where you want to assess these kinds of things really carefully and understand.
I'll come back to that.
And I think that could it be helpful on a more local level? Typically when you're talking about state licensure boards and other things, it's risen to that type of level already, those types of circumstances, but perhaps in departments or units, there's, I think that'd be good to discuss or think about. Yeah.
There's another group. I sit on the harassment committee, and
yeah.
we've had employee safety
yeah.
from other employees,
yeah.
and this kind of an action would also be very useful for determining whether what the intents were, because that's really a very different issue. And I've never seen this before, and I know the committee has not seen it. We've had a couple of cases,
So you could find this helpful in that realm too.
Yeah, that's really, and that I would like to come back to that as well, because I think some of the trust issues, when we think of safety, we have to think of employee safety as well as patient safety.
Yeah.
And if the employees don't feel as valued, then you have a problem.
Exactly. Yeah. Okay. The other way that you can engineer or start to work on a safe culture is by setting standards for professionalism, and I think you started to talk about the intimidating or harassment type of behavior, which is pervasive in healthcare today. What was done on the Maternal Child Health Service with the Department of OB was creating a standard for professionalism that the leadership agreed to. Nursing, medical, and union leadership agreed that they would hold everybody to the same standard of professionalism. In addition to it being a statement, it is also a process, which is what the Joint Commission requires of us also at this point, in terms of having the ability for people to report on professional harassment, intimidating type of behavior, and to have a way of dealing with that or processing it. And so what was created on this service is a professionalism committee where the chair and the nursing director are part of the committee, but there's also two members that are not part of the direct reporting lines that also sit on the committee. Importantly, to give balance and fairness also to looking at certain incidents. And a lot of it is conflict resolution and reinforcing what professionalism is. And what's come through on this over the last few years are many situations or settings that typically in the past in healthcare would have been pushed under the carpet. And now they're coming to light, being addressed, and the expectation is that it will not recur. And if it does, or if it's more severe, it would certainly become a disciplinary issue. So it's really bringing to light some of these types of issues I think that you're referring to.
Does that extend to the outpatient also?
It was implemented on the obstetrics service, OBGYN service, which does include ambulatory practice. The focus, I think, for the initial rollout was inpatient. So those are two of the ways, in addition to having clear policies and procedures, which I think is an ongoing thing that Mount Sinai continues to address and look at, are ways that you can start to create an aim towards a safe culture. The next area I wanted to focus on was reporting. So that's been a large focus of what we've done here at Mount Sinai over the past year, and hopefully many of you are familiar with MERS, the Medical Event Reporting System. Prior to this year, we really had a paper system, an incident reporting system, where when there were adverse events, reoperations, retained foreign bodies, misadministration of the wrong blood product or medication, those types of things would be reported on an incident report and investigated and analyzed. The trouble with a paper system is when you have 2,000 sheets of paper to start trending or understanding what's really going on or looking any deeper at the data becomes a whole another initiative. So having the electronic system, and I would like to say and give a hand to Dr. Kaplan, who's sitting quietly in the back of the room, who developed the system. and a lot of the brains and thinking behind it. We are very fortunate to have him and the team here that developed it here at Mount Sinai now, and to help guide the implementation this past year here. And a lot of what it does is give us tools. First of all, it makes it easy to report. It's right on the clinical desktop. If there's a near miss, a close call, and the guideline is anything that worries you, anything that concerns you or doesn't seem right, any type of error should be reported. At this point, we'd rather have more reports than less reports to understand what's going on in the organization. So that's where that's at. The full implementation, yeah.
Who's eligible to report? Anybody.
Anybody that works in the hospital. It's a hospital system. It's not it's not in the faculty practice right now, or the school hospital. Yeah, except there isn't.
One of our desktops.
The training was focused on nurses, providers, house staff.
What about medical students? They're not officially workers they work in the institution, but they're not employees. So I was just.
That's true, and I should have. I think you guys are able to report. You need a network log on ID. If you do, which I believe the students do, you should be able to get on. Yeah.
Do the medical students have a log on?
You should be able to. Yeah. So it took the majority of the resources to do that portion of the rollout with the main staff that do work for the hospital. But part of why
they were not trained necessarily. They were not focused on training, so that might be something that needs to be done.
There is a lot actually that needs to be done still, and I will say that as the initial implementation was just completed in the April-May timeframe, and the last few months have really been focused on optimization, and students, the FPA, Queens, bringing the reports and giving feedback to the frontline users, all of those are optimization steps for reporting, and all of that takes time, and I agree, students, all of that is things we'd love to do and would have loved to do the first 6 months of it, and I think in time all of that will be accomplished in better systems for that. But right now I think a lot of it probably will be, yeah.
Are they only reporting concerns related to patient outcomes, or could it be concerns related to the team or dynamics? In other words, you're saying that an intern is ignoring the page.
This came up in terms of professionalism issues. There has not been any firm decision as to where to report professionalism type issues that happen on the units, and there is discussion right now. I think from the perspective of the institution, intimidating behavior is a near miss. It's a close call. I mean, those things have been tied directly to adverse events, liability with practitioners, et cetera. I think there is no harm in reporting those as near misses or close calls at this point.
How about policies or change of policy?
I'm not sure what.
When you say, you come across and you say, that's nuts. And you say, well, that's our policy. So I go, I'm going to report that.
I'm not sure I'm following. What? I'm not sure I follow.
We have a policy.
Okay.
Maybe patient is accepted or rejected, or policy of wait time, or you say, but that's our policy. Well, we don't do dental. And you say, that's policy.
So if you have a concern about the policy and it doesn't make any sense and actually could be harmful. Yeah. Yeah.
Is policy and procedure acceptable?
Yeah, if it's a concern about the way that care is rendered or a process that's in place, then yeah, definitely it should be reported. And when you click on that, you come to the easy, user-friendly button just to click an event or near miss. And these are just some detailed slides of what the event registration looks like. And behind the scenes, when it gets routed through to nurse managers, chairpersons, risk management, there's a lot that here to help everybody so that everyone's on the same page, understanding what the event is about, what's been found about it, where the analysis is, what are the next steps. So it's actually very handy. And in terms of doing further analysis and root cause analysis, there are root cause analysis trees and things that can be part of the whole file for any event that's there. So there is a lot to the system that we as an institution are just starting to learn and get our arms around. Right now, a lot of the focus this past year has been to encourage reporting, especially of the nurses, physicians, and house staff, the people that are really at the bedside, and feeding back to them what has been found, ways to use the system that's easier for them, those kinds of things. And again, initially we were really just looking for an increase in reports, which for the most part across the organization we have seen. It's a little hard. It's a little bit apples to oranges comparing to the paper reports that went to FOJP, our malpractice carrier. But when you look at certain units and areas, you can see an increase in reporting, and that is a reflection of a safer culture. So that for us is considered success. What we'd also like to see in time is an increase in the near-miss reports, and that ratio, that safety pyramid that you saw earlier in the talk, that is going to be another indicator that we're getting to a safer place, and a decrease in the severity of events.
I'm just curious whether or not you can submit something without anonymously, or is the
You
name
can.
field always required?
For the near misses or close calls, there's an anonymous option. Yeah. Some of the other things that we've been doing with respect to optimizing the system the last few months is focusing on rewarding or recognizing really people for putting in some of those near misses and good catches, and bringing certificates or balloons to the person or the unit that put in that good catch, and letting them know, yes, we want to hear about this. Look what good has come from this. And that has been some of the initial efforts. What we would also like to do is something called storytelling, which is really bringing an event or a near miss back to the unit or a small group of people and walking through the event, helping to understand what happened, what went right here, what workarounds were helpful, who was the hero in this. Oftentimes there is a hero, and what can the other people learn from it, and what went wrong, and what can the other staff members learn from that, and to do some of that work to understand what events and near misses can bring to us. So with robust reporting, it can lead to improvements. And the improvements are what hopefully is going to drive us to becoming more of a high reliability organization. And what Dr. Deming, father of quality, said was that we need to reduce the contributing factors. The patients and the public measure the number of adverse events. They're the ones that see the awful things, the brain dead baby, the man that died unnecessarily, the wrong site surgery. But those are rare, right? They're few and far between. They measure them, but how does that help us get to a better place as an organization? I mean, if we measure those, I think we had one last spring, it doesn't help us. So improvement here at our hospital really needs to focus on the contributing factor, and looking closely at those and having techniques and tools in our back pocket to really measure those defects and decrease those. Because if we decrease the contributing factors, we will decrease the number of adverse events. And what Deming also said was, if I had to reduce my message for management to just a few words, I'd say it all had to do with reducing variation. Now that stings a lot of people in medicine. What? But it's all the art of medicine, right? It is. There's an art, there's the thinking. You don't want to eliminate that. And that's the misconception that many people have, I think, about quality in healthcare, is that you're just trying to get rid of all variation. You know, people are individuals. Every patient is different. We're not airlines. You know, we're not all DC-10s or whatever it is. Every patient is an individual. That still holds true. But are there certain processes in healthcare that can be standardized and that we don't do such a good job of? Who can think of an example? How good are we at keeping up immunizations? How good are we at doing smoking cessation, for all of our smokers? How good are we at getting antibiotics in a patient that's been diagnosed with pneumonia within, 4 hours? How good are we at those things? turns out not so good in healthcare. Would we all agree those are good things for the most part? Probably want those numbers probably pretty close to 100%. Maybe there's some exceptions here or there, right? But most of those things, we want pretty much 0 defects, but we do a terrible job. That's where Deming's going. That's where I believe all of us in this room would want health care. For those things that we do know that there's good evidence for, let's do them right. The rest of that outside, there's a lot of thinking that requires the skill set of many different practitioners.
So, Sue, what is the word unexplainable just before variation? Because I remember that was reducing unexplainable variation as opposed to variation from.
Right. Correct. Yeah, that's more accurate. So a focus here at Mount Sinai, and I hope everywhere else, is really when one of those adverse events happen, is not to ask who, but actually what happened. And that's, I think, a lesson for all of us. Not who was on last night, who did it, but just tell me what happened. I want to know A to Z, all the steps. What happened? What was in your mind? What was the staffing like? Were the computers down? What was going on? One of the tools that we use, and many organizations use, actually are required to use, is something called root cause analysis. Has anyone ever participated in a root cause analysis for a sentinel event? I see some nodding heads. It's a meeting with a group of people that includes frontline providers and subject matter experts and people oftentimes from management that sit down and review a sentinel event. Oftentimes it's a reactive process, and look at the systems, review what really happened to identify the basic factors, the root causes, and things that contributed to that event. And coming out of that type of meeting is an action plan that really identifies the strategies that the organization is going to put in place to counteract and reduce the risk of that event or type of thing recurring again. So that's a root cause analysis. Other techniques for improvement, some of you in the room in quality I know are more familiar with. PDSA is something called Plan, Do, Study, Act. It's tried and true quality improvement. You plan, you do something, you study the effects, you measure them, and you act according to those, and the circle starts again. You can use process mapping. If you find that the process isn't quite right, you're going to map it A to Z. Root cause analysis we just spoke about. And this is not a comprehensive list. It's a little for show. Some of the things that are certainly used here. Lean Six Sigma, the Six Sigma program. Are you all familiar with Six Sigma? You're not. It's essentially, it's a roadmap. It's something that's been used in other industries to help improve their quality, to bring the number of defects to an infinitesimal amount. And it's really a toolkit, many tools that can be used to target improving things. And what's different from other methods of quality improvement with Lean Six Sigma is there's a very, very strong focus on measurement and data. And that's, I think, what the appeal was at this organization when the program was implemented and started about 8 years ago. There is a large focus on bringing data to understand what's really happening and then to fix it and to remeasure. And the other thing that's different about Lean and Six Sigma is that there's the explicit support of leadership, which is not inherent in other quality improvement techniques. Part of any project in Six Sigma requires executive sponsorship, clear champions that will champion it, and the sponsors and the champions need to ensure that the core team actually has the time and the resources to do the project. So it's that backbone structure that makes it different from other quality improvement techniques. Something else that's very much a part of it is understanding the change acceleration process. And I'll talk about that a little bit in a second. The phases for a Six Sigma type of project are called DMAIC. Sometimes you'll hear it referred to, and it refers to the steps: define, measure, analyze, improve, and control. Define is ensuring many projects in an organization, when you try to improve things, they run into problems or barriers because the project was never truly scoped or understood at the beginning. And part of doing improvements well is really defining what's your goal? What's your timeline? Who's on the team? What are we doing here? And so that's a very clear step, specifying what the customers value. And for us, many times our customer is our patient. And then measuring the steps in what you're looking at, analyzing what you've looked at, looking at the root causes for the problems based on the data that you've obtained, put in some improvement plans, measure what that does, and then putting in a control plan. And that's a difference, too, from other quality improvement techniques, and that there's a clear step to hand off the project so that it's sustained. Many projects are great during that initial couple months when you have all the resources there. What happens when that goes away or after all the initial excitement of the initial project? There has to be a process by which the new practice is sustained in the organization. So there's clear steps for that. And within all of these, there are many, many tools that can be used to facilitate each step. And part of this is the change acceleration process. Part of it, of any successful change, nobody likes to change. I always say to people in OB, if it's a small change, they're going to complain for 6 months. If it's a big change, they're going to complain for 2 years. So change is hard for us in healthcare. And part of any successful strategy has to incorporate the acceptance. Otherwise, your whole solution set, your technical things that might have been easy or difficult to figure out, it will fail if people aren't on board with it. And there's a whole set of tools, the change acceleration process, and within each of these things there are certain tools that can be pulled upon, used to get you to the better state and make the changes last. Another tool that can be used as part of Six Sigma or separately, it's been used in many engineering areas, is something that's a little more prospective in terms of looking ahead and creating something called a failure modes and effects analysis, where you can take a process and maybe you're designing a new process or you're taking one that's broken and you want to make it better, outlining the process mapping, and then determining where and how could that process fail. Where are the steps? If you were to take the process for preventing a wrong site surgery and you started with scheduling at the time in the physician's office when that decision was made to operate on the left knee all the way to incision, outlined all the steps there, all the inputs, where could that process fail? Well, there's 1,000, right? Literally, there are many. But you can go through this and find the potential effects of failure. If it's broken down, it becomes manageable to look at this, and what you can do then is define the severity, the occurrence, and the detection of all those potential failures, coming up with a prioritization scheme as to where to target your improvements to prevent a wrong site surgery from happening. This is a busy slide, but for those of you that aren't familiar with the Quality and Performance Improvement Committee structure at the organization, it's a lot of wheels churning every day, all the time here at the organization. And it flows from local departments, multidisciplinary committees, clinical departments, to the Hospital Performance Improvement Committee, from the departmental M&Ms and peer reviews and sentinel events, funneling all the way up to the medical board and the subcommittee of the Board of Trustees, the Quality Subcommittee. So there are a lot of wheels churning here for all of the local improvements that happen and larger improvements across departments. And this is a long list of all the many performance improvement areas. And all of those committees have many projects and improvement initiatives going on, and there's no way I could even begin to capsize all of those or some of the many things that are going on. But I wanted to just touch on a few of the things that cross many departments that have happened over the last couple of years while we have the next few minutes. And certainly some of them are aligned with the Joint Commission's National Patient Safety Goals. And those have really been targeted because, guess what? They lead to awful things. And if we just start with the basics first, we're doing a really good job. And I know there are still a long ways to go with many of these, but there have been certain processes that have been improved and things implemented over the last couple of years in terms of clarifying patient identification. It wasn't too long ago that we didn't have a lot of clarity over how to identify patients. And it's very clear now at Mount Sinai we identify patients with 2 identifiers, name and date of birth. We have clarity over anticoagulation and systems in place in our order entry system to support that, right, which crosses many disciplines. Hand hygiene, which leads to many issues with respect to preventable infections, has been a major force across the organization. Those Purell things did not just land there. There is a fair amount of thought and work that goes into helping all of us remember to wash our hands before we walk in or out of a patient room. The ICUs have been involved in collaboratives with Greater New York with respect to decreasing the risk of central line associated infections. Mount Sinai has chosen SBAR, Situation Background Assessment Recommendation, as standardized communication for handoff, and bringing frontline providers across the organization to understand what that is, to practice what that is, has been a major push. Medication safety, many of you are familiar with the electronic system, eMedRec, that was implemented and now is the basis for the EPIC system, and certainly targets many mishaps that could come with medications. Improvements with respect to medication labels have been put in place in the operating rooms and sterile fields. That is very different than it was not too long ago. Changes in the pharmacy, which unless you're a pharmacist, you might not be as aware of, but it's good for anyone to know that there are sound-alike, look-alike drugs and how to avoid mixing those up. Another push over the last year here at Mount Sinai is looking at our most hazardous drugs, chemotherapeutics, and looking at our processes and systems there. And there are many things that have been improved there, and especially many of our policies and procedures and training and education across disciplines. Many of you are aware of some of the work we've done in obstetrics, which really is the intersection of healthy patients and liability. 40% of the payouts that this institution does is for obstetrics and what people refer to as bad baby cases. And our goal is to really have zero birth trauma with respect to that. And there have been a lot of initiatives along that. And at the heart of it has really been a collaboration with our malpractice carrier in looking at safety and developing a risk management council and developing guidelines that are really basic obstetric practice. I'll be honest with you, it's nothing fancy, but there's accountability with it. Those guidelines became departmental policy and are also measured and audited by FOJP, and our malpractice coverage is tied to that. So they are looking at all of the providers. They also recognize that at the heart of many of our cases, there was not enough attending coverage or supervision, and there's been support to increase that. The code of professionalism I talked a little bit about. There is also recognition with respect to, for instance, the case I presented to you and then more recent cases, that there are differences in the way that practitioners, nurses, and physicians define things on fetal heart tracings. There was not a good understanding across the disciplines, and so everybody on the clinical service has taken the same 8-hour course on fetal heart monitoring so that everybody is speaking the same language and has the same interpretation of the fetal heart tracings. Weekly, Mrs. Morbidity and Mortality, there's always something to talk about, I think, with respect to what's going on the clinical service. And so we look for things that have come up that could be of not just zebras or interesting clinical cases, but rather what can we learn as a service from what happened here this week. And a more robust reporting structure. Something that's at the heart of many clinical efforts too is the chain of command and the inability of a junior or frontline provider to step up and go to the front to the next most senior person if they feel uncomfortable with the care that's provided. And we've actually in obstetrics made this crystal clear with these types of things hanging literally with the frontline providers telling them who they can and should go to if they don't understand the care or need clarity, and empowering the nurse to reach out to the attending if they are not getting a response from more junior members of the team, along with the leadership's phone number. And the nurses and physicians and house staff are actually encouraged to call the leadership if they are having a problem. It's not let them sleep anymore. In fact, the junior people have been told explicitly on many occasions they want to know what's going on, and they do, and this has been very receptive. There have been simulator drills and team training rolled out. There have been a whole host of things, and I think in a microcosm, that clinical service, in terms of looking at professionalism, looking at a just culture, looking at reporting, and then the improvements, we can also bring many of these improvement strategies to the organization at large, and many have been in some format. And as you can see, it has affected the outcomes in obstetrics. This is a measure, I won't walk through and bore you with the long list of adverse outcomes, but it's an index that's used that has maternal death, neonatal death, low APGARs, fourth degree lacerations, those types of things in an index, and there has been a significant decline. And you'll ask why this went up again, and we don't truly understand, although it's still significantly better than at baseline. And it's thought just to be, well, we don't know for sure, but that's where that's at right now. In terms of other broad improvements across the organization, I talked a little bit about the reducing the risk of wrong site surgery, our project with the Joint Commission, and we are using Six Sigma techniques and developing a very robust failure modes and effects analysis and improvement strategy around that. Another issue with respect to safety is identifying the frontline provider. It's a complaint from the lab and and radiology and also the nurses. And for some clinical services it's easy, but for other clinical services they have no idea who the resident or the NP or the PA that's on, and they don't even know who to contact at 3 in the morning, which is a real safety issue. And so there are, this is a big cross-department project that's going on right now to create systems, and it's actually critical for the EPIC rollout too. So that's another project that we're tackling is looking to reduce the risk of errors from lookalike tubing, which was in an article earlier this fall in the New York Times. We are definitely at risk for that with all the zillions of tubes across this organization, and so we are doing an FMEA to assess our risk there. Some of the other big improvements that I think aren't always recognized as patient safety initiatives or improvements is actually the electronic medical record system, and it can introduce as many errors as it can fix, and so it has to be a very careful, watchful implementation so that we don't, with all the new processes that will be brought in with an electronic system, that we don't introduce even more hazards. And some of the other technology things that have been put in place across many areas of the organization, both Sarah, I don't know if any of you are familiar with the voice-activated system that's used in peri-op and the labor floor, and some of the other units, some of the cardiology units actually use it also to communicate with each other and decrease noise on the units. This past year, in order to decrease the risk of retained foreign bodies, SurgiCount, a scanning system, has been put in place in the operating rooms. So another layer or defense has been put in place. And just to start to close up, we're actually now part of an ARC grant with New York State Department of Health, Medical Liability Reform and Patient Safety grant with the FOJP institutions, Maimonides, Montefiore, Beth Israel, and also New York Presbyterian. And it's really using special judges to mediate cases, but part of it is patient safety and the things that we're doing in all of our organizations and the interventions we're putting in place. And the other part of the grant is looking to do more robust disclosure of events and having training and education around that, along with early settlement, which is something we do in this organization already. Is it a well-oiled machine? No, it's more of a case-by-case basis. So I think with this grant and working with the state and other organizations, we'll be able to bring the process that we have to an even better level, actually. So I look forward to that. So what is success? The ability, again, to focus on near misses. As we have less and less adverse events, hopefully more of our time will be spent understanding the near misses and the heroes that actually prevented those near misses from becoming actual events, and understanding what those how they recovered events. And I think accountability and professionalism, I think those wheels are starting to get oiled, and the committees are being formed right now across the school and the hospital for the organization. Engaging physicians in reporting is another key component, and in terms of real optimization, I think from medical students all the way to senior attendings, the majority of our reporting right now is done by nursing, which is great, but physicians bring some other aspects of the care that we're not seeing in the reports right now, and that's where I think all of us can be involved in bringing physicians to that and really using those reports to drive improvements. And I would encourage all of you to get involved in a local improvement project, to pick something out that doesn't work for you on your service and go to your performance improvement chair and become part of that. Become part of a sub-task force on an issue that's important to you, to fixing. That's it. Thanks. Anything anyone wanted to discuss or ask about? Yes. Okay.
There's almost a generation of physicians that we've lost, and we're not going to solve that problem. But what are we doing at the medical school level? I know you started a safety curriculum in medicine. So is it for students and clerks?
Well, it's not. It hasn't been going on for a while. So it had been started.
Yeah. I think right now there are fits and starts that Erica and I have talked about. Yeah.
In surgery, what do you do in OB for the medical students?
For the medical students?
For the clerks.
Do
you have a safety program for part of the curriculum for the medical students?
No, it's not. It's not across the organization right now. The focus has really been mostly really on the house staff and the attendings. I think all the energy at this point has been spent at other levels, and there needs to be, I think, more effort at all levels. I mean, but I'm biased. Where I see you have to bring it into the education. It's part of healthcare delivery today and part of the education, and we have to catch up the people that are practicing right now. We can't wait I'm pointing to the young people, to become seasoned practitioners. I think we need to target everything at this point.
I mean, the Residency Review Committee in surgery mandates that there be a patient safety curriculum as part of the residency.
Right, I think for house staff there is very much mandated stuff.
To me, that's already too late.
Yeah.
The horse is already out of the barn. And if we don't start at the student level, we're really making a bad mistake.
No, I completely agree. I think what's difficult, though, is when the students hear something in a lecture in their second or third year, and then they go on to the units and the wards, and they see behavior and things that is very different than what was explained to them. And so I don't think we can do one without the other. We have to focus on the people practicing right now. And that can change with accountability. We no longer want the surgeon bringing in the high revenue that throws the knife across the room. That's not tolerated. It should not be. And it wasn't too long ago that it was.
The case that we had for the harassment committee was a student who was here on electives from another medical school, in which a surgeon threw a knife, a scalpel in the surgery, and nicked the student. Okay, and it came to us because her father was a physician in another medical school, and it came to the harassment committee, and it was a whole problem. But the really big problem is that, and was one of the issues, is that nobody instituted the surgery policy on sharps, and so there was no dealing with whether the patient would get the patient who was having the surgery would effectively have an HIV testing, and the whole system in the department fell because everybody was intimidated by the surgeon. Okay, so it was a systems failure on that basis. So, and that's why I was thinking about employee safety. That's an employee safety issue, which
Yeah.
And there is a culture of, an anti-culture of safety. If the employees don't feel safe, they're not going to necessarily feel comfortable dealing with it on the patients. It may not, maybe it doesn't sound altruistic, but I think those are some of the issues, that we are not as safety oriented in the institution. I think a good example was one of the companies that was in the World Trade Center. I think it was Morgan Stanley. They had a guy that kept doing fire drills after the first attack on the World Trade Center, and the CEO said, he hated it because once a month they always had to do a fire drill. And he used to try to get out of it, and this guy used to chase and make sure everybody got down there. But he said they had a higher percentage of their employees that lived there, that worked there, that were actually safe. So it's having somebody who's kind of very, very adapted to the whole issue of programs. We as a harassment committee were really upset by the fact that the whole system broke down, and it could have been easily, if somebody had instituted the Sharps thing, I don't think the Sharps issue and it could have been solved, and it would have never come to the harassment committee. It would have never escaped outside the institution and had another parent. So that's really.
So then the question is, with that harassment issue, was that addressed directly with that physician?
Yes, it was, and that was brought up, but it probably didn't need to get there, okay? Because it would have never come to the harassment committee if they felt the concern about the Sharps and being cut was really a big issue. Not even the unprofessionalism.
Right.
It wasn't the unprofessionalism of the physician. It was the danger that was inflicted on the patient by not having these things kick in. So that was
I'd like to thank Dr. DuPree for an excellent overview of the patient safety efforts at Mount Sinai. And if she's willing to stay for a minute, whoever has questions can come up. But I think we may need to get out of the room. Thanks.
Thanks, Beth. Oh, thanks.